So I'm from the Sydney Local Health District Public Health Observatory, and I guess just for background, for those of you that don't know us, we are all about trying to provide information about the health and the health needs of our community in order to support service development that meets those needs. And by way of background to this talk, we've been developing a very succinct public health profile of our district. It's only 4 pages long. In theory at least, you can get through it in about 2 or 3 minutes. So whilst it provides a kind of useful basis for this talk, I'm going to go into quite a bit more detail than this particular snapshot goes in. But the main thing is I want to talk about the health of our community and the population in a sort of structured way that goes through the population generally, its size, how old it is, the social determinants, and particularly a lot of the census data that we've recently got from the 2016 census that tells us a lot about the demographics and social status of our community. I'm going to talk about mothers and children quite briefly, but because they are a very important group, we know if we can give children the best start in life, that will have a profound impact on their futures. Then I'll talk a little bit about risk factors and morbidity and mortality, and throughout, I want to try and have a focus on health inequalities, because I think an overriding theme in this is while Sydney Local Health District actually does pretty well in terms of overall health, there are inequalities. Not everybody shares in that health. So that's what I'm going to get through, I hope. So without further ado, we're going to talk about the population. So currently, there's about 670,000 people in Sydney Local Health District. And the interesting thing about that is that it's about 20% more than it was 10 years ago. So that's a pretty large increase. And even more importantly, it's probably going to be another 20% bigger in another 10 years. So again, we're sort of going through a period of unprecedented population growth. And what this graph here shows, if it works, it seems to, that I think is quite important. This is showing the growth in Sydney Local Health District versus all of New South Wales. And what you can see is that Sydney Local Health District is growing at a faster rate than the population of New South Wales generally. And so, that has important impacts on our health needs. Okay. An important thing with our population is not just is it growing, but the growth is not evenly distributed within the district. So what this slide is showing, the darker the pink, the more rapid or the larger the growth has been in that time frame. So you can see pretty clearly that there's been very rapid growth. More than 12,500 people have moved to the Waterloo Beaconsfield area here on the outskirts of the city, and probably more like 10,000 or so to the Rose Peninsula in the last 10 years or so, and probably that kind of pattern of growth is likely to continue with the developments that we're expecting. So whilst we have experienced very large growth, that growth has not been evenly distributed, and I guess that has relevance to how we provide our services. It's not just about the size of the population, though. The age of the population is very important. People's health needs is strongly associated with their age. And so if we look at the population over 65, in 2018 it was about 85,000 people. That's almost a third more than it was in 2008. So in the last 10 years we've seen very substantial growth in the population over 65, and a lot faster than we've seen in the younger population. And we expect that growth to be even larger in the next 10 years. And again, just another one of these graphs that show you how things have been changing over time. And it's quite interesting, this one, actually, because you can see that actually relative to this, so this grey line is people younger than 65, and this is people over 65. And you can see that there was actually a decline, relatively speaking, in the number of people over 65 in the early 2000s, but since then the rate has been going up dramatically, and it's going to continue going up dramatically for the next 20 years at least, and probably, for a lot longer than that. Now, moving on from population, I want to talk a little bit more about the broader determinants of health. So, sorry, this is a slightly complicated graph, but I've got a few of these, so it's worth getting your eye in with them. this is called a spine chart, and the basic principle is that it's a succinct way. You can put a lot of information in a very small amount of paper, essentially. But if you're to the right of this line and in green dots, we're doing better than average, and if you're to the left of the line and we're doing worse than average, and if you're orange, we're not much different to average. So this is just some high-level indicators of social determinants, and what it highlights is that we've got a high proportion of a lot of people living in unstable accommodation, and a lot of people who don't speak English well. And I think these are two important things, and I'll talk more about them in a moment. But firstly, because although this is not a very large number of people in terms of the overall population of Sydney Local Health District, it's a very vulnerable group, and it's a group that we should be giving a great deal of attention to. And this is a large number of people in terms of Sydney Local Health District, so a very high proportion of people don't speak English well, which reflects the cultural diversity of our community. So I'll talk more about both of those things in a moment. But before we get there, I just wanted to show you how socioeconomic disadvantage is, actually I'll put both of these up, is distributed in our district. So this is based on 2016 data, and it tells us how much social disadvantage people experience based on the areas in which they live. And this bar chart on the right shows that if you're at this end of it, the right-hand end of it, these people are more disadvantaged and these people are less disadvantaged. And so generally in Sydney Local Health District, you can see that, that we tend towards being more disadvantaged in general. But having said that, there's still more than 40,000 people living in the 10% most disadvantaged suburbs in Sydney within the district. So we still have a very large population of people living in fairly severe disadvantage. And when you look at that on a map, there's a fairly clear geographic pattern to it. So obviously down in the Canterbury area, particularly around Lakemba and Punchbowl, Riverwood, Narwee, there are some very disadvantaged areas. And then in the city of Sydney, in the areas with high concentrations of social housing, so Redfern, Waterloo and Glebe, and then not quite so easy to see. You can see there are these little clusters, I think along the railway lines. Sorry, if you couldn't hear that. Along the railway lines through Burwood, Ashfield, Strathfield. So I guess the point is that whilst we're probably overall not doing too badly in terms of our level of disadvantage, there are still very large numbers of people living in severe disadvantage, and they're predominantly in the Canterbury region. So this next graph was really just to try and illustrate how those patterns of disadvantage can relate to the broader determinants of health. And I've chosen people's active travel as an indicator of this. So active travel is very good for you, essentially. There was a study last year that said if you cycle to work, I think your risk of death is about 45% lower than people who don't cycle to work. So it's much more good for you than, for example, medicines. So it's a useful determinant of health. And what this shows is there's on the right on the map, sorry, if I can go back, there's a fairly obvious geographic pattern which relates to how close you are to the city. If you live close to the city where the people predominantly work, you're much more likely to travel actively to work because presumably it's easier to walk or cycle. But that translates into a pretty clear social gradient. And so people in the most disadvantaged suburbs are much less likely, or about 3 times less likely, to use active travel to get to work. And that just illustrates that by virtue of where people live and their level of socioeconomic status, they have fewer opportunities to take or undertake behaviours, I guess, that are good for their health. So that's the point of that slide. Now, something that I want to spend a bit of time talking about is our cultural diversity. Now, cultural identity is something that's actually really quite hard to measure, particularly using routine data. So instead, we tend to use kind of proxy measures such as our ancestry or our country of birth or the language that we speak at home. And in terms of all those measures, Sydney Local Health District is very diverse. So a small percentage of people, a relatively small percentage of people, report that they have Australian and English ancestry in Sydney Local Health District. A very high proportion, so at least 44% were born overseas and at least 46% speak a non-English language at home. Now, what I'm going to do in the next few slides is just go through a little bit about what we know about people who were born overseas, just to try and illustrate that whilst we might collectively look at people born overseas as one group, they're actually quite a diverse group, and the data tells us that. So the first thing is just which countries do people come from. And this probably won't surprise many people, but in terms of non-English speaking countries, China is the most common country of birth by a very long way. So about 60,000 people in the district were born in China, but that's about 10%. Perhaps more, interestingly, India is in second place, and that's quite a recent phenomenon. If we looked at older census data, I think India would have been fourth or fifth. So there's been a large increase in the Indian population in the last 10 years or so. Another interesting thing is that Lebanon has fallen down the rankings. I think, again, around about 5 or 6 years ago, Lebanon would have been somewhere around about second or third place, so it's moved down. And something that I found quite interesting when I saw this was that, let's skip back, is that Nepal squeezes in here in the top 9 countries. So, and I think that certainly wouldn't have been the case even 5 years ago. So we've seen a large influx in people of Nepal in the last few years. So what else do we know about these people? Well, this just shows you, it's a little bit complicated, but it shows you when people arrived in the country. And that is probably relevant because it sort of determines to some extent important determinants of health, like how old people are, how well integrated into the local society they are, how economically active they can be, those sorts of things. And so you can see, I'll just to say, time is on the bottom here on the x-axis, and number of people is on the right. So people from Italy and Greece arrived first in the 1950s or 60s as a group of non-English speakers. Then people from Lebanon and Vietnam in the 70s. And then people from China and Korea have been coming in quite large numbers really since the 1980s. And then just in the last 5 or 10 years, really, we've seen a large increase in the number of people coming from the Indian subcontinent. As I mentioned, Nepal, people started coming from Nepal really just in the last 10 years in a very dramatic increase in their number. So how does that translate into sort of other factors? Well, this is the age distributions of those people, and unsurprisingly, I think most people will know this. People from Italy and Greece tend to be older. So these graphs, again, show age along the bottom, and if you're at the right-hand end, you will tend to be older. And if you're at the left-hand end, you'll be younger. So Italians and Greeks tend to be older. People from Lebanon and Vietnam, somewhere in between, and then Chinese, Koreans, Indians, Bangladeshis, and particularly Nepalese people are very young populations. And the reason for showing you that is that will determine to some extent their health needs. So people from Nepal are much more likely, for example, to need child and family health services, I would assume, compared to people from Greece and Italy who perhaps are going to be more or using more aged care services and those types of things. Another interesting phenomenon by country of birth is people's level of socioeconomic disadvantage. And there are clear relationships, essentially, between your country of birth and how likely you are to be either disadvantaged or advantaged. And I've added in here Australia and England to contrast these other countries of birth. But essentially, if you're from Australia or England, you're generally at the more advantaged end of the spectrum. That's these. So you see there's this sort of upward slope. But if you come from Bangladesh or Nepal, particularly, you're likely to, and Lebanon as well, you're likely to be very disadvantaged, relatively speaking. So there's clear socioeconomic patterning within these groups, and that's, again, relevant to the types of services that we need. And the important thing is, so people who are more socially disadvantaged are likely to have greater health needs. And so that's just an important thing to know. People, when we talk about recent migration, people always say, well, that's a lot of students coming in. There's lots and lots of Chinese students, for example, coming in recently. And this graph here shows you that probably is the case. So almost 40% of the Nepalese people in Sydney Local Health District say that they are students. Nearly 35% of Chinese people say that they are students. I guess just to point out that 35% of Chinese people is around about 25,000 people, so that's a very large population. And conversely, people from Italy and Greece are much less likely to be students. And then finally, just in this sort of cultural diversity, people's English proficiency varies as well by the country at which they come from. And I was sort of slightly surprised when I saw this, but the highest proportions of people who don't speak English well are from Greece, followed by Vietnam and South Korea, whereas people from the Indian subcontinent, so Nepal, India and Bangladesh, tend to have, or at least self-report that they have higher levels of English proficiency. So that again is probably relevant to the sorts of service, or how we might go about providing services and the information and things like that that we need to prepare for people. So that I think is all I have about cultural diversity. So the next thing, so this is, yes, Rohingyan speakers. So I put this slide in because Rohingyan speakers, I think, are a group that are of real special interest to us in Sydney Local Health District. And I want to just show you some of what the census says about Rohingyan speakers and to sort of say why it's a really important thing that they are of strong interest to us. So this chart shows where Rohingyan speakers live. And you can see that almost all of the Rohingyan speakers in New South Wales live in Canterbury. So that's around, I think there's about 900 in the whole of New South Wales, and about 800 of those people live in Canterbury. And actually, it's even more specific than that. This is a picture of the Canterbury Statistical Area Level 3, and you can see that actually it's really mainly in Lakemba and a little bit in Wiley Park that people live. So they're really very, very concentrated in a small area of our district. And so it's really important that we provide services that are appropriate to these people, because Rohingyan speakers are almost invariably humanitarian migrants who are likely to have high levels of health need. So this shows they've all arrived very recently, which relates to the upheaval in Myanmar. And again, that they're highly likely to be socially disadvantaged. And when you look, so this is just the general level of social disadvantage, but you can go further into this. And so a very high proportion of Rohingyan speakers live on less or between $200 and $300 a week, for example. About 50% report that they don't speak English well. So many measures of social disadvantage are highly prevalent in the Rohingyan community. So that's just an example of the kinds of things you can find out if you look carefully at the census. And one other important group from a social point of view is homeless people. And I put this slide up because there's been some recent homelessness data provided by the ABS. And what this shows, this is largely, this actually includes, this is districts within Sydney Local Health District, but also includes part of the city of Sydney, so it's a little bit larger. And it categorises homeless people in various ways according to the census. But what I want to highlight is there's been about a 10 or 15% increase in the number of people who are sleeping rough or living in improvised dwellings. There's been perhaps a 10% increase in the number of people living in boarding houses, about 500 more people living in boarding houses. And these two groups are particularly important because they are groups that we know have very high levels of health need. But the other thing that it highlights that I think is quite interesting is that between 2016 and 2011, there's been a massive increase in the number of people that are living in severely crowded dwellings. Now, a severely crowded dwelling is one where based on some objective measures, 4 or more extra bedrooms are required. So that is a significant, you require a lot of people to be living in a house before you need 4 extra bedrooms, essentially. So that's pretty poor housing conditions. And there's been a very, very large increase in that number. And when you look more specifically at where that increase has taken place, it's actually happened in places like Canterbury and Strathfield. So not the sorts of places perhaps you would expect it so much. And presumably, and I'm speculating, but that's largely driven, I think, by some of the housing affordability issues that we hear about so much at the moment. So the next thing, and I'm only going to talk briefly about these in the interest of time, are behavioural risk factors. And so generally, in terms of our behaviours, so that's things like obesity, physical activity, how much alcohol we consume and how much we smoke, we're about average in Sydney Local Health District. One thing I will just highlight, so whilst we actually have one of the lowest rates of overweight and obesity, although we did in 2016, that's still 38% of people. So one of the issues with a spine plot is that although it might say that we're doing well compared to other people, 38% is still a big problem and we could be doing a lot better. So those are behavioural risk factors. Another thing that I'm just going to gloss over this one I'm going to focus on quite a lot. This is maternal and child health, sorry. So this again shows you a few key indicators of maternal and child health in the district and how we compare. And just glancing down this graph, you'll see that we're doing pretty well. We're green, which means basically we're doing better than average. So that's good news. But what I want to really focus on here is that whilst overall we're doing quite well, there's pretty good evidence that there are differences within the districts, and which creates health inequality. So this is one example, smoking in pregnancy. And what it shows is that people living in the most disadvantaged suburbs are probably 5 or 6 times more likely to smoke in pregnancy than those living in the least disadvantaged suburbs. And that relationship translates into a geographic pattern again. So you can see there are much higher rates of smoking in pregnancy in the Redfern, Waterloo area, in Glebe, and down towards the southwest of the district. And a lot of the other indicators of antenatal care and maternal health follow a very similar pattern. So this is just one, smoking in pregnancy, but I just say it's reflective of other indicators that we have. And another thing that I just want to highlight is child development. So this data that I'm showing here comes from the Australian Census of Early Child Development, which essentially is a census of children in their first year of school. What this graph is showing is the proportion, so the graph on the left-hand side shows the proportion of children who are vulnerable in at least one domain of the census. So that means potentially have a developmental vulnerability. And you can see again that people in the more disadvantaged suburbs are about twice as likely to be developmentally vulnerable than the least disadvantaged suburbs. And I think, again, that is just something that's really important because we know that those effects that we're seeing there are going to translate into worse health throughout people's lives. And if we can intervene at this kind of stage in people's lives, we actually have a real opportunity to improve people's health and well-being across their entire life course. So it's just something that I think is really important, and it's really evident in the data, and it's really evident in our district. So I would like to highlight that, I think. So how are we doing in terms of morbidity? I've just had my 3-minute warning, so I won't, again, dwell on this one too much. So just to say, except that in terms of measures of ill health, we've chosen ones that, so rather than talking about things like hospitalization rates with cardiovascular disease, for example, we've chosen things that are a little bit more specific. So hepatitis B, which relates to where people are born a lot of the time. So we have quite high rates of hepatitis B because we have a migrant population from countries of high prevalence. And hepatitis B has severe long-term consequences, so it's an important condition. Gonorrhea notifications are representative of STIs more generally and of young people's health, and we have high rates of STIs. So again, there are some issues related to morbidity within the district. But I just want to talk about mortality. And similarly to child and maternal health, when you look at these data, you see that on average we're doing quite well. We've got lots of green dots, so our life expectancy is a little bit higher than average. Our premature mortality from heart disease and all causes is lower than average. So generally we're doing pretty well. And that's reflected in this graph here. So this shows you the mortality rates in Sydney Local Health District over the last 15 years or so. So we have about 3,100 deaths a year at the moment, which is down from about 3,500 5 or 10 years ago. And I think one of the interesting things here is that we were worse, particularly amongst men. Prior to about 2005, we had higher mortality rates than the rest of New South Wales, which is the dotted line. But we've seen pretty dramatic falls in those rates, and we're now doing better. So that's really good news. Just a little bit more detail now on what the top 5 causes of death are. So 37% of deaths are from 5 causes, and probably not terribly surprisingly, those are actually, well, not terribly surprisingly, Heart disease, it comes in top. Perhaps more surprisingly, dementia and Alzheimer's disease now comes in second, and that is a recent phenomenon. Cerebrovascular disease, so strokes and the like, third, lung cancer and emphysema, fourth and fifth. And so I think the most interesting thing there is the dementia and Alzheimer's part of this. And so this just shows the trends in these conditions over time. And you can see that, particularly amongst men, there's been a really dramatic fall in heart disease. Happily, given the talk we've just seen, there's also been a pretty marked decline in the rate of cerebrovascular disease as well. Unfortunately, our data doesn't go out till 2017 when they've started clot busting. It's only to 2015. But you can see we're doing pretty well there. But, and actually, there's a small fall in the other two, lung cancer and COPD. But what you will see here is, particularly amongst women, there's now beginning to we're seeing an increase in dementia. And I think that just highlights that in the future, dementia is going to become an increasing problem for us in Sydney Local Health District and more broadly. And the final thing that I really want to leave you with, though, is that when we talk about health inequalities, there are really stark inequalities in life expectancy within the district. So this shows you that, particularly for men, there's a man living in the most disadvantaged suburb expects to live almost 7 years less than a man living in the most advantaged suburbs, which is a pretty large difference. It's almost 10% of a lifetime. And you see a similar but not as extreme pattern for women. So whilst overall we are doing well, we could be doing better, particularly to support those who are at the more disadvantaged end of the social spectrum. So, to round off, Sydney Local Health District is a very diverse community. And with that diversity, there are lots of challenges in how we provide services that are equitable and meet the needs of everybody. But overall, we're doing pretty well. But in all our data, we do see a social gradient, and I think we really need to pay attention to that moving forward. Thank you.